Hello, and welcome to the Caring for Our Community, a COVID-19 briefing. We appreciate your time and are so pleased that you have joined us. We have a full schedule with a lot of important information to share. But before we get started, we wanted to let you know and invite you to place any questions or comments in the question and answer function. To preserve time for today's speakers, we will provide responses to the questions and share the answers after today's call. So with that, let's get started. I'll turn it over to Steve to offer today's reflection.
Thank you, Sarah. I appreciate that. We could kind of center ourselves this afternoon and ponder on this reflection. That all may know that God is love. That all may know that God is love. This year, we celebrate the 60th Jubilee of Sister Andrea Nenzel's profession of vows as a Sister of St. Joseph of Peace. At the time of her vows, the Spirit spoke very closely to Sister Andrea. Live your life that all may know that God is love. These 7 words have been a spur and an anchor for her every day of her life as a Sister of St. Joseph of Peace. Her service as a CSJB congregation member have been in various ministries, including education, administration, social service, mission service in El Salvador, healthcare governance, and now as Sister of St. Joseph of Peace, congregational lead. In addition to this 7-word phrase, Sister Andrea has given us at Peace Health many other phrases. We call them Sister Andrea-isms. Here are but a few examples. Loving God, source of all life, we come to you full of hope and joy. We do not have a wealth problem. We have a distribution of resources problem. Grab hold of our faith in the spirit of wisdom. I don't think that calculation is correct. And of course, they aren't. And of course, her most famous Sister Andrea-ism, the burning ball of accountability. I would now like to share a video with you to hear Sister Andrea in her own words as she celebrates the ministry of Peace Health.
It's been said that what we do each day defines us. It's the way we choose to live our lives when there is pain, when others are in need, and when the time comes to work together. At Peace Health, the work we do, it's more than just a duty. It's more than relieving pain and suffering. Our work is about life. And we all know that life is all about living. We are there in the difficult moments and the celebrations, the moments of fear and the tears of relief. Doctors, nurses, technicians, and support staff. All across the Northwest, from Bellingham to Florence, from Eugene to Vancouver, in local communities, offering warm, healing facilities, cutting-edge technology, and the best caregivers in the region. We are Peace Health. We are your neighbors, your friends, your family. We are there where you need us. because what defines us is our mission: to provide care to everyone. Because we all have the right to be healed, to live life.
Please keep Sister Andrea in your prayers and thoughts as she celebrates her Jubilee year. It is now my pleasure to introduce Peace Health President and CEO, Liz Dunn.
Good afternoon. It's great to be with you all today. Thank you, Steve, for acknowledging Sister Andrea and the extraordinary impact she's had on Peace Health and so many of us gathered here today. Let me add my own personal congratulations to Sister Andrea on her momentous 60th Jubilee and all that she has accomplished. Sister Andrea, you truly embody the legacy and the spirit of the founding sisters, offering healing, compassion, wisdom, and joy to me and to countless others. Thank you. In times like these, it's simply wonderful to have a person like Sister Andrea to celebrate. We are so thankful and blessed to have you as part of our Peace Health family. As Steve shared, Sister Andrea is beloved for many things, including her great sayings, as we like to call them, Sister Andreisms. Today, one in particular comes to mind. Not too long ago, Sister Andrea spoke to Peace Health's burning ball of accountability, how we have this unwavering responsibility to protect and propel our mission and our legacy by relentlessly caring for all. And more often than not, this burning ball of accountability means we have to make tough decisions. Decisions that may not always be popular with all, but stay true to our mission and values. Sister Andrea and the Sisters of St. Joseph of Peace model the courage, discipline, and servant leadership required to make hard decisions in service to the common good. Today, as we face the fifth wave of COVID-19, we draw on their strengths and their example as we relentlessly and courageously care for our patients, caregivers, and communities. As you know, Peace Health took a bold step earlier this month when we announced our COVID vaccine requirement. We did this before other health systems and before the state governments announced their mandates. Upon completion of our ethical discernment, it became clear our mission, vision, and values called us to act. I feel strongly that it was the right decision, and I am proud that Peace Health was at the forefront. I commit to you that we will continue to do everything within our power to keep our patients, caregivers, and the community safe, and always live up to our mission. This is our burning ball of accountability. Despite the disapproval of some, I am heartened by the response of the caregivers. As of this morning, nearly 1,600 caregivers have updated their vaccine status, putting us at 87% vaccine rate across the system. This is a great step in the right direction. Unfortunately, the latest data indicates we must do more. In the last week, after considerable deliberation, we have decided to further strengthen our stance. After October 15th, all patient care at Peace Health will be delivered from vaccinated caregivers. The transmission risk from the unvaccinated is simply too great. Since August 3rd, the public health emergency has become even more acute. Peace Health has set multiple records for COVID-19 inpatient admissions, exceeding the peaks of this past January. As you'll hear from Richard and Doctors Cook and Doctors Pell, sadly, the Delta variant continues to drive up our volumes. Each day is a new record high. It's a similar picture across all of our communities and sadly, across our entire country. And the latest modeling doesn't show things letting up for several more weeks. While the fifth wave is a challenge on our resources and our people, as Richard will share, we have a solid foundation in place and we are operationally ready. Our team is rising to the occasion as they've done throughout the past 17 months. I have no doubt they will continue their stellar work. As we find ourselves deep in the trenches yet again, we need your support now more than ever. I ask for your help in continuing to support our extraordinary caregivers. They're on the front lines day in and day out, exhausted, yet dedicated heroes, and deserve all the praise and appreciation. Support from the community is also essential. In the early days of the pandemic, so much gratitude was shown for the healthcare heroes. And as a community, we must embrace a pro-vaccine culture. Viruses like COVID-19 are here to stay. If we are to preserve personal and community health, vaccines are undoubtedly our best protection. Before I finish, I'd like to take a moment to express my gratitude. I feel blessed every day to work with such an immensely talented team. Sister Andrea, members of Peace Health Systems Board, Community Health and Foundation Boards, and the entire Peace Health leadership team. You are all exceptional people. We are in this position of strength because of you. You are Peace Health. I want to leave you with the inspiring words from Dr. Rick Padgett. He's the System Medical Director of Cardiovascular Services in Oregon. The reflection he shared with his fellow colleagues rings true to me when thinking about our amazing 16,000 caregivers. Dr. Padgett wrote, "When I see you comforting a scared clinic patient, I am proud. When I hear you talking to a confused patient on the phone, I am proud. When I see you all going about your job with steely-eyed determination, but still with a smile on your face, I am proud. I am proud of you, but mostly I'm proud to work with you." And he ended with, "We will get through this challenge, as we always do, together." With that, I'll turn it over to Richard.
Thanks very much, Liz. Usually you hear from me about our current state and our ongoing response. This time, Dr. Cook will be providing this update. Today, I want to share with you what we've learned and how we are prepared for this current wave of COVID in our communities. The danger posed by the current COVID-19 variant is a public health emergency, and it affects everyone. The COVID-19 variant circulating in our community is more dangerous and it's more deadly. Unfortunately, we're seeing young children, in some cases infants and pregnant women and others who are otherwise healthy and strong individuals falling ill from this variant of COVID-19. While most of our hospitalized inpatients with COVID are unvaccinated, we're seeing breakthrough COVID cases in vaccinated individuals as well, most often those with underlying health issues. This puts a significant strain on our resources and adds to the stress on our clinicians. So much that at times it may feel like there is no end. While it may not feel like it in the moment, we are better prepared and more qualified to handle this wave than before. We've learned from the past and we've prepared for the future. We've got this, a phrase we often use with one another. While this fifth wave is not what anyone wanted, there's much to be proud of and hope is on the horizon. We have a solid foundation. We've done collaborative planning and we're an agile team. For the last 18 months, we have built and refined the structures and systems to address COVID. For example, we have enhanced our data analytics capabilities to better inform and advance our decisions. Our data insights also help us accelerate operational improvements, including capacity and staffing management and our length of stay efforts in our hospitals. We are ready to support a continued surge while also addressing the healthcare needs of our non-COVID patients. We have modified caseloads and had to pull back on some procedures that can be safely delayed as our COVID volumes swell. Our clinical teams take great care to ensure that each non-emergent case is reviewed thoroughly prior to any postponement. I continue to be inspired by the heart, the dedication of our leaders and our frontline caregivers. The next 4 weeks will be a test for us, and I'm confident in our ability to care for our patients with the same level of care and compassion that has gotten through the last year and a half. CDC guidance, FDA approvals, state directives are all being monitored closely by our teams. We will continue to adjust, modify, adapt, and stay agile for what's to come. And as Liz shared, we are leading the way, doing what's right for our communities, and our mission has never been more relevant or more meaningful. Finally, I want to express our most profound appreciation to everyone for their continued support and dedication. We are incredibly thankful to our leaders, caregivers, providers, frontline and support teams for ensuring every patient receives safe and compassionate care at PeaceHealth. With that, I'll turn it over to Dr. Doug Cook. Doug?
Thank you, Richard. As Richard said, the new variants in our communities are more transmissible, and they are equally, if not more, deadly. I think what's new about this wave of the epidemic is that it is an epidemic of the unvaccinated. It's younger and at times previously healthy individuals that are part of our hospital census now. Since February 1st, more than 92% of COVID-19 hospitalizations and deaths in the state of Washington were individuals not fully vaccinated. To go ahead and advance my slide. We have I just wanted you to see some of our current numbers. We are no doubt in the midst of a public health emergency. As of this morning, we had 251 COVID-19 patients across the PeaceHealth system. 2 weeks ago, or a week ago, it was 203. 2 weeks ago, 160. You can see how quickly the numbers have grown. And those numbers may not be staggering to you all, but having one diagnosis occupy such a significant percentage of our inpatient beds puts pressure on the non-COVID operations and the care that we have to provide to other patients. It's a huge strain on our hospitals, on the staff, on the administrative bandwidth, and on our emotional resilience. We've had an 18-month run-up to prepare ourselves, and we will manage through this. To go ahead and advance to my next slide. Good planning requires good forecasting. What you have on this slide is actually two superimposed charts. The red and black lines are from Dr. Peter Graven at OHSU. The peach color portions of this is our actual hospital census, cumulative across PeaceHealth. Now, the Graven model has been an accurate forecast. You can see that by how well these match up. But what you can also see is that we've not yet peaked. We're still 1 or 2 weeks away from the estimated height or peak of this fifth wave of COVID. Let's go to the next slide. We expect to see system-wide in PeaceHealth a COVID census of about 300. We'll see 100 to 130 patients in both the Columbia and the Oregon networks, where we have the lower vaccination rates. This doubles the previous peak of the third wave. It's 3 times higher than the peak of the fourth wave. And it's important to note that this is not just a PeaceHealth issue. The same high census and strain on resources is occurring elsewhere across the country and certainly in the Pacific Northwest. A couple of examples. In Southern Oregon, our hospital systems there are at capacity. They're reaching out to us to request additional ventilators and oxygen equipment. Last week, we received a COVID transfer from Northern California, things previously unheard of. It's hard work, and it's frustrating because we all know there's a component of what we're seeing today is because folks that were reluctant to get vaccinated. And that makes the compassion fatigue a real phenomenon. But what I've been proud of is our leadership teams. They're continually rounding They're expressing appreciation, concern. They're helping folks appeal to their true sense of calling. They're reminding folks why they're in healthcare, to heal. So as I talk about our preparation, I've got just a couple of slides then. It's easiest for us to talk about this, I think, in 3 lanes: space, people, and materials. So if you go to that next slide, let me start with space. The new volume is primarily being managed in space that's been freed up, frankly, by reducing our elective surgical cases. That allows us to use post-operative surgical beds for medical patients. It allows us to use recovery areas and short-stay surgery areas for COVID patients. But there's a lot of creativity at play right now in our organization. Each hospital has very innovative plans, things like flexing into sleep lab space or cath recovery space, infusion center space. Really, wherever we can go to find the space, we will. And then under people, as you all are aware, we had a already tight labor market. Now compound that with a high COVID census, and then the future inability to use our unvaccinated caregivers in the workforce, and all these things are converging. Our solution is multifactorial. We have ongoing recruitment, talent acquisition efforts. We're asking people to work overtime. We're reassigning people, existing staff, to work in new areas. And then, of course, we're using temporary and locums replacement staffing. We surveyed all our caregivers to understand the intentions of compliance with the vaccine requirement to generate an accurate staffing gap prediction. And then we're contracting for the needed personnel with various staffing solution firms. So we will have the people we need. Finally, materials. When we look at our PPE dashboards, we have adequate stock on hand today. We'll continue to manage this supply-demand equation over the next few weeks. For instance, we doubled orders recently for our PCR testing supplies this past week. We're watching drug supplies closely. The only real shortage that we've been dealing with is in one of the newer biologic monoclonal drugs, tocilizumab, which is an IL-6 receptor blocker. We've stood up outpatient monoclonal infusion sites so we can avoid using hospital space for that. But in addition to thinking about this in sort of fixed numbers of space, materials, and people, we need to do things differently to speed the throughput with our existing resources. Because if we can manage more patients with the same fixed resources, if we can reduce the time, reduce the length of stay for the patients in our facilities, we can manage more patients. Now, this is work that we needed to do anyway. We're going to need to bridge the time between now and when additional beds come online with master facility plans. And it's work we needed to do to ensure the financial sustainability of our organization going forward. But in a sense, never waste a crisis. This is forcing us to do the right thing now. We've got a variety of new tools out there, new analytic tools that are helping us with capacity planning. We're optimizing our care management teams. We're doing terrific work in our post-acute and ambulatory arenas that will allow us to reduce readmissions and unnecessary first admissions to free up beds. We know there's opportunities in our length of stay. We tend to think of length of stay in these 3 categories: our observation patients, sort of average length of stay, and then the long length of stay. We think we have the most opportunity working in that observation space, make sure that we're getting out those patients within 24 hours. And then in that second category, where if we can just shave 1 or 2 days off a 5 or 6 day length of stay, we could really open up more capacity. Many of these efforts, though, require really deep engagement. Changes in the culture of how our physicians interact with staff and care management, in particular with our primary care and hospitalists. It requires a lot of change. So we're working with those physician groups. I want to turn it over to Dr. Pelz, but I guess, just in closing, we're nearly there. 4 weeks from now, this wave of COVID-19 will be in a steep decline. Things will be improving, but these next days and weeks, they will test our resolve and our resilience. It's this time that we really need to most support one another. Like Liz said, I have just the utmost admiration and appreciation for our teams. So with that, let me turn it over to my colleague, Dr. Pelz. Bob?
Hi, thanks for giving me the opportunity to talk to you today. I get lots of opportunities to talk about COVID with people, and I guess I would start by saying I would be shocked if there is not a paper out there that I didn't happen to notice, because there's such a torrent of information coming out on COVID. But these are pretty up to date. I'd like to walk through a handful of in a little bit of information about booster vaccines, the Delta variant, the Lambda variant, possible projections for influenza in the coming season, and pediatric vaccination. Next slide, please. So there's a lot in the popular press and in the literature about the possibility that we may need to have booster vaccines because of waning immunity after getting any of the 3 available vaccines on the market. And there's a few things that have sort of come to my attention when thinking about waning immunity. People that got the vaccine early on might be at higher risk for having complications or recurrent COVID, because these were people that were in nursing homes or had severe underlying illnesses. So waning immunity may simply be because the first people that we vaccinated were less likely to respond well to the vaccine. The other thing is that the early populations of people vaccinated were people like me, who are at risk for more intensive exposure to the virus, and that also may make it look like the vaccine is losing efficacy. The other thing is that as you look at waning efficacy over time, not only is the vaccine changing, but the variants of the virus are changing. So is this a change because of Delta, or is it a change because of waning immunity? And it's very difficult to tease those two apart. There are studies out there that look at antibody levels, the infection-fighting proteins in our bloodstream, as a marker of whether the vaccines are working, but there are many more components to a vaccine response that are not easily measured. So simply finding a decrease in antibody titers may not necessarily mean that the vaccines aren't working very well. There may be differences among various vaccines, and I think it's really important to point out that the review committee, the American Committee on Immunization Practices, has not yet reviewed the data on this or even made a recommendation as to whether boosters are going to be recommended for people other than the people with immune compromise. Next slide, please. A few more thoughts in the same vein. There is a lot of press out there right now that people with vaccines are getting infections, and I think it's important to draw a distinction between whether people are just getting infected with a disease that may just be like a common cold, or whether they're hospitalized in the intensive care unit of a hospital like Riverbend, where I am now. It's also important to keep in mind that as more people are vaccinated, the pool of potential vaccinated people that might develop an infection goes up. So you may see absolute numbers of infections go up, but that doesn't necessarily mean that the vaccine is failing. You really need to look at the rates. And the next bullet point there is just a caveat of my personal struggle with this, is that I really want to believe these vaccines work, and I have to fight against the impulse to have my own biases in how I think about this. And then a final thing to keep in mind is that the World Health Organization still does not advise that people get boosters. If everybody in India had access to a vaccine 6 months ago, the Delta variant may not have arisen and may not have come over here. So by giving extra vaccines to people in wealthy countries, we probably are going to be depriving vaccines for people in developing countries, and that may lead to the emergence of variants that are even harder for us to manage. Next slide, please. Okay, so let's dive into some evidence regarding waning immunity to the vaccines. Now, as you're all aware, I'm sure, Israel is one of the countries in the world that has the highest vaccine rates. Something like 80% of their overall population is vaccinated, and they predominantly use the Pfizer vaccine over there. The study that I show first here compared COVID between June and July. Between January and February versus March and April, the people were vaccinated in those months, and it looked like there was a 53% higher risk of COVID in the people that had been vaccinated earlier on, suggesting that vaccine efficacy seems to wane over time. They did their best to adjust for multiple potential confounding covariates, but they really only looked at infection, not at hospitalization or death. So they're looking at people that get a positive test, not at people that end up in the hospital. So these vaccines still may work very well against keeping people from getting sick and hospitalized, but in terms of just preventing infections, they do seem to lose some efficacy. Another study out of Israel shows that if you look at people greater than 146 days out from having been vaccinated, their risk of infection, and again, this is infection, not hospitalization, is 3 times higher. half of the severe infections in Israel, so these are people that are hospitalized or ill, are fully vaccinated people. But again, that's 80% of the population. The risk is 9 times higher if you're unvaccinated. Next slide, please. And then the data that Pfizer submitted as in support of their application to have the FDA recommend a booster vaccine showed a decrease in efficacy in terms of preventing infection. Again, not hospitalization, dropping from 96% down to 83%, comparing the first 2 months after vaccination to months 4 and 6 after vaccination. The data, the internal data that Moderna reports still shows greater than 90% efficacy after 6 months. So they don't seem to be seeing as much decline in efficacy. Next slide, please. The New York State database includes about 10 million vaccinated people, about 3 million unvaccinated people. So this is a gigantic database, and they're able to see who gets infected and who gets hospitalized. The panel on the left looks at infection rates in the vaccinated, unvaccinated, and overall. On the top line there shows the vaccine effectiveness over time, which you can see drops. But again, is that due to waning vaccine effectiveness, or is it due to the emergence of new variants? The panel on the other side, however, looks at new hospitalizations, and I think encouragingly, it still shows that the vaccine efficacy remains very high, even across this time period up until, I think, July 19th was the last day that they reported data. Next slide. The Mayo Clinic looked at their database, and they looked back comparing unvaccinated people to those who received Pfizer and those who received Moderna. They're showing a difference between Pfizer and Moderna, and their data seems to show that Moderna is a little bit better. As you can see in the bullet points on the right, the overall effectiveness seemed to differ a little bit between Moderna and Pfizer. If you look at hospitalization in July, the vaccine efficacy was 81% for Moderna, 75% for Pfizer. And if you look at infection in that same time period, vaccine efficacy was 76% for Moderna and only 42% for Pfizer. So we have somewhat conflicting data on whether vaccine efficacy is waning. Next slide, please. About 3 weeks ago, the FDA came out with a recommendation for booster vaccine dose for people that are immune compromised, and that's a list there that you've probably seen of the people where a booster dose is recommended. And I would just say that these are very immune compromised patients. Like, I take care of a lot of HIV patients, and I don't have any that would yet qualify for a booster dose because their disease is under such good control. So these booster doses generally, again, are for people that really have longstanding and severe compromise to their immune systems. Next slide, please. Let's move on to the Delta variant, which is responsible for over 90% of the cases in Oregon and Washington. And as of probably 6 weeks ago, we didn't have any cases, and it has completely taken over. There is some data that the vaccine efficacy in the Delta variant may be a little bit lower. Interestingly, there was a study out of Wuhan looking at this variant, and they found 1,000 more times more viral particles in the nasopharynx of people that had Delta compared to the Alpha strain, which is the UK variant. And this probably contributes to the rapid spread that you see with Delta. And the graphic on the bottom is an illustration of the effect of the R0, or the number of people that will be infected by a given infected patient. So if the R0 is 2, like it is for influenza, and I have influenza, I'll infect 2 people who will go on to infect 4 people who will go on to infect a total of 8 people. The R0 for Delta is 6, and that may not sound like a lot, but if I infect 6 people, they'll infect 36 and they'll infect 216. So you see this rapid geometric curve rising steeply with rapid spread of the Delta virus, and that's what's swamping our hospitals right now. Next slide, please. So there are a few studies out that really tried to look specifically at the vaccine effectiveness of the Delta variant. There's a large cohort of people in a British database published in the New England Journal of Medicine earlier this month. And they're finding 93% vaccine effectiveness with the Alpha strain, the UK variant, which drops to 88% with the Delta strain. Not terrible. And with a single dose, those numbers are 48.7 and 30.7. These are all symptomatic infections, not just looking at hospitalization or death. So the vaccine efficacy, again, is likely to be higher looking at the more severe diseases. The AstraZeneca vaccine is used in Britain, not used in the United States, and seems to have somewhat lower efficacy. Another study published within the last couple of weeks in the MMWR, which is the CDC journal, looked at periods before Delta, an intermediate period, and then the periods when the Delta variant was predominant. And the vaccine efficacy appears to have fallen from 74 to 52% for Pfizer and from 74 to 50% for Moderna. And this, again, is not just data on hospitalization or death. So we still don't really know what the effect of these vaccines would be on hospitalization and death. Next slide, please. Just to touch briefly on Lambda. Lambda is the predominant strain in southern South America. In Brazil, they're still seeing the Brazil variant and others. It does have some specific genetic markers that are likely to lead to increased transmission, possibly escape from the immune protection of people that have been previously vaccinated or infected. But it's of only limited prevalence in the United States. As of last week, Oregon only had 5 of these isolated, and Washington and Alaska had not had any. Next slide, please. So I was asked to mention pediatric vaccination. As you're aware, the vaccines are now available for people 12 years of age and older. The Pfizer vaccine for the younger people is still under EUA, even though the adult vaccine is now approved by the FDA. The American Academy of Pediatrics reports that there have been 346 pediatric deaths and more than 4 million pediatric patients that have tested positive. So this is still a common disease in pediatrics, and I'm really nervous about what's going to happen in the fall when the kids go back to school and what's the impact that's going to have. There are currently trials underway for both Moderna and Pfizer for children ages 5 to 11. Pfizer in their trial is using a dose 1/3 of the concentration of that given to adults, and they're hoping to submit an EUA application by the end of September. Next slide, please. I was asked to polish up my crystal ball to give you some predictions about what's going to happen with influenza this year. And generally, the best predictor of the northern hemisphere influenza season is what's happening in the previous southern hemisphere season. And as was the case in 2020, influenza activity in the southern hemisphere is very, very low. The World Health Organization has a surveillance program in Australia, and they've only identified 1 positive specimen in the first 23 weeks of surveillance in 2021. The Department of Health there is describing their influenza rates to be at historically low levels, and the Pan American Health Organization reports very low influenza activity in South America. Next slide. And I'm going to turn it over to Ron Saxton. Thank you very much.
Okay, well, thank you. That's all very sobering. I'm just going to give a little flavor of what's happening, excuse me, with the government actions and impacts. Mandates and waivers, those are the 2 things I'll talk about them, but I want to make a couple observations first. You've heard people talking about the team effort here. Excuse me. Swallowed something wrong there. Anyway, I don't think there's ever been a team effort like what we're seeing here. The clinical people interacting with legal, with government affairs, employee health. That's always, we've always been here to support the clinical team, but these interactions now they're not just daily, they're really hourly. And so the team is working very, very hard. The other observation I want to make is that the administrative burden of government regulation and actions has gone dramatically up. We can talk about waivers, we can talk about government trying to help. It's dramatically grown. It has not simplified. And so we're living in obviously a clinical medical crisis where the government's very active and they're making more work for everybody. But, so a few things, the mandates. Let's go to the next slide, Wendy. Liz talked about that Peace Health has put in place a very aggressive vaccine mandate, and we're all very proud of that. The state governments have been following with this. So Washington and Oregon have now put in place for healthcare workers and for other healthcare workers, good mandates as well. Alaska has not, and we'll see what happens there, but Oregon and Washington, we've got these. The federal mandate's less important, really just related to long-term care, but we're now in an environment for both Oregon and Washington state law and PeaceHealth's own policies that our healthcare workers are being mandated to have vaccines, and PeaceHealth really led the way. And I just want to make a quick comment on that because Washington's governor moved pretty aggressively on this. Oregon was being more reluctant. And so we as a PeaceHealth team jumped in aggressively promoting the idea of a vaccine mandate here. And PeaceHealth played a role in helping move the Oregon governor on this. And so we're again proud of that role and proud of having these mandates in place. So that's mandates. And move on. You heard about the vaccine boosters. No government mandates yet related to that. So that's going to be more of a medical clinical decision, what we do there. And you heard the couple doctors talk about that. The other area I want to touch on, Wendy, if you go to the next slide, are waivers. And when we went back almost 2 years ago, you'll remember we talked about that because there's so many government rules that we live under, that we needed some flexibility. And so we got some of those waivers. We have seen waivers of various kinds of things around, facilities, around cohorting, around, use of care sites, certainly waivers around telemedicine. All of these things have given us more flexibility, more ability to care for people, more ability to use our people. But they've come with a cost. They've come with significantly increased regulatory work. We end up filing reports daily that we, otherwise would have filed, quarterly or something, or would not have filed at all. And so the government oversight here is very significant, and we've got a lot of people working on making sure we're both in compliance and that we're doing the reporting we need to do. It's challenging for another reason, which is we've got different rules from each place. So as I said, Oregon and Washington each have their own mandate on vaccines. Alaska doesn't. When you get to the use of alternate sites or flexibility around using staff, so forth, the rules are different state by state and then the federal overlay. So there's a big puzzle here that we're constantly working with, trying to make sure that we know the rules change frequently. We need to know them. We need to make sure that people out in the front know them. I think we're doing a real good job at people working really hard. We continue to see government activities. I think Richard mentioned about the National Guard. I know that's that phrase, government trying to help us, probably has all of you laughing. You're on mute and I can't hear, but I'm sure you are. But that's sort of what we're dealing with here is government trying to help in ways that sometimes it helps, sometimes it makes life more challenging, but we're going forward there. So I'll just stop there. This is a subject that could go on for a long time, but the two things that we mentioned again, the mandates around vaccination, I think they're growing. They're going to keep growing with the removal of emergency status from the first vaccine. That has really removed some of the legal barriers. And so not just healthcare workers, but now many private employers are moving towards mandates. And then on the waiver side, we're going to keep working. These all have expiration dates. They're typically 90-day waivers. We keep working to make sure they keep rolling forward until whenever this is, where we don't need the waivers. So that's sort of big picture. It's a time of intense activity, but we're all here to make sure the frontline caregivers can do the important work. And so I think I turn it back to you, Richard.
Thanks, Ron. Thanks very much for your comments and thanks very much for the information. I also want to thank Dr. Cook and Dr. Pelz for sharing all of the latest information with us to keep us fully informed. As I said earlier, this is a difficult time, but there's also so much to be proud of, and hope is on the horizon. This wave will not last forever. Together, we are stronger, and together, we will make it through this surge. As I said before, we frequently repeat to one another, we've got this. I so admire our caregivers and our frontline staff. I see the challenges that they face every day, and I'm inspired by their ability to return and do it again day after day. Thank you for tirelessly working to ensure every patient receives safe and compassionate care here at PeaceHealth. Again, I want to express my most profound appreciation to everyone for your continued support and your dedication. Without you, we would not be able to fill our mission and our shared purpose. And finally, like Liz, I am also honored and proud to work with all of you. You're an incredible group of leaders who have the PeaceHealth mission in your heart and in your soul. With that, I'll turn it over to Sarah.
Thanks, Richard. On behalf of Liz and the senior leadership team, thank you so much for joining us today. We are grateful for your service to this incredible ministry. Please look for an email after the call with a link to an e-card to honor Sister Andrea. If you'd like to offer you her well wishes on her momentous anniversary, we invite you to do so. We will also share the deck and the responses to the questions that may have come through on today's call, as well as a recording of today's session. So with that, thank you and be well.